Indication: CABOMETYX, cabozantinib, is indicated for the treatment of patients with hepatocellular carcinoma, HCC, who have been previously treated with sorafenib. Select important safety information. The full prescribing information for CABOMETYX includes warnings and precautions for hemorrhage, perforations and fistulas, thromboembolic events, hypertension and hypertensive crisis, cardiac failure, diarrhea, palmar plantar erythrodysesthesia, proteinuria, osteonecrosis of the jaw, impaired wound healing, reversible posterior leukoencephalopathy syndrome, thyroid dysfunction, hypocalcemia, and embryo-fetal toxicity. Please see important safety information at the end of this video.
Hi, I'm Dr. Julio Gutierrez, an Associate Professor of Medicine, Hepatologist, and Liver Cancer Specialist at Scripps Prebys Cancer Center in San Diego. I lead an active transplant hepatology practice, focusing especially on underserved populations in Southern California.
And I'm Dr. Joshua Strauss, a community hematologist-oncologist. Since completing my fellowship at Columbia University in New York, I've been working in private practice in New Jersey.
Today on CABOMETYX in Conversation, we're going to talk about a hypothetical patient with hepatocellular carcinoma, or HCC, who progressed from Child-Pugh A to Child-Pugh B liver function. Dr. Strauss, we know there can be a lot of challenges and considerations that have to be taken into account when selecting a treatment.
I agree. Dealing with both HCC and underlying cirrhosis can certainly be a challenge and requires a multidisciplinary approach.
With that in mind, let's talk about Anna.
So let's assume Anna has non-alcoholic steatohepatitis, also known as NASH, diabetes, and hypertension, and she initially presented with abdominal pain and weight loss. An abdominal CT scan revealed at least 4 nodules in her liver, with the largest being greater than 5 centimeters, and a chest CT revealed lung metastasis. After a lung biopsy, she was diagnosed with unresectable advanced HCC. So just to confirm, does she have cirrhosis?
Yes, she does have cirrhosis. We can make the diagnosis of this using simple blood tests like the Enhanced Liver Fibrosis Test, or ELF. You can order that clinically in your EMR. Also, you could calculate a FIB-4, and if it's over 3.25, then there's a high likelihood your patient has cirrhosis. In many cases, I have also checked transient elastography or liver stiffness. Once you know your patient has cirrhosis, then you have to be ready to estimate the liver function with the CTP score. It is important to remember that cirrhosis is a separate, lethal disease, and that can make managing these patients a real challenge.
Okay. Now, could you please go ahead and walk us through your treatment strategy for Anna?
My next step for a patient like Anna would be to confirm she had a high-quality quad or triple-phase MRI or CT scan. Protocoled imaging will allow for LIRAD scoring of your patient's scan and can ensure that guidance can easily be followed. Also, masses can be missed when dynamic imaging is not performed. Examining this way, I could look for size and extent of disease, portal vein invasion, metastasis, and evaluate the size of her lymph nodes. Next, I would like to look at her liver function.
So why is liver function an important assessment for you?
Assessing Anna's liver function helps determine her eligibility for treatment. If she has a bilirubin greater than 2.5 grams per deciliter, I'd like to avoid local regional therapy so we don't cause any more damage to the liver. For sure, if there's even a hint of liver disease like a Child-Pugh score of A6, we would want to monitor that patient closely.
Yes. Whenever you treat someone with HCC, you're competing with the underlying liver disease. It increases risk of side effects. And honestly, it complicates everything you do. You have to keep an eye out for drug toxicity and for liver decompensation.
Sure. I like to monitor the patient's liver function every month, at least. This is an area where a multidisciplinary approach helps. For example, if Anna is seeing one of us every 6 weeks, we can stagger her appointments to ensure her liver function and toleration of therapy is being evaluated at least once a month. This is critical when patients develop what we refer to as decompensated acute on chronic liver disease. Patients will let you know if there's a status change. Child-Pugh A is not a static situation, and patients can progress through it to B or even C quite quickly. Even in the 3 weeks between check-ins, a patient may become icteric, or their family may bring them into the hospital because they're confused. Dr. Strauss, are there other factors that might influence your treatment decision?
Certainly. Is there macrovascular invasion? What about ascites, varices? Are there comorbidities like thrombocytopenia or bleeding? All of those factors can affect my decision.
Also, because of the extent of underlying liver disease and the importance of considering adverse reactions, I look at a therapy's safety profile, particularly where I may be able to help manage some of the toxicities through dose adjustments. Okay, let's jump ahead 6 months. Since starting Anna on first-line therapy, she's presenting with progressive extrahepatic spread and new main portal vein invasion. At this point, her ECOG performance is 1, her serum AFP is 619 nanograms per deciliter, and her albumin is low at 3.3 grams per deciliter. Her bilirubin is up at 3.5 milligrams per deciliter, and now her alb grade is 2.
So she's progressed to Child-Pugh B.
She has.
What evidence would help you to determine an appropriate treatment path for Anna now that she's progressed?
With Anna, as I would with any of my patients, I like to consider the data from clinical studies to inform my treatment decisions. Child-Pugh B liver function complicates decisions like this because it's often difficult to find trials that include subgroups with poor status. Most clinical trials for HCC systemic therapies only include patients with Child-Pugh A or excellent performance status. And those of us who see a lot of advanced HCC in the clinic know that Child-Pugh B liver function is prevalent and clinical trial data is less common for this subgroup of patients. So when considering a well-studied drug with Anna's progression to Child-Pugh B profile, CABOMETYX would be my choice due to the Celestial study.
Okay, I understand. Now let's take a closer look at the Celestial trial design.
Celestial was a phase 3 double-blind trial of 707 HCC patients randomized 2-to-1 to receive either CABOMETYX 60 milligrams administered orally once daily or placebo. All patients had received prior sorafenib and 27% of patients received more than one prior systemic regimen. The primary efficacy outcome measure was overall survival, or OS, and additional outcome measures were progression-free survival, or PFS, and objective response rate. While all patients who enrolled were Child-Pugh Class A, there was a group of patients who progressed from A's to B's within the first 8 weeks of treatment, and they remained in the trial until disease progression or unacceptable toxicity. The intent to treat efficacy was compelling, and the inclusion of exploratory data on Child-Pugh B patients is an important consideration to any decision.
Now let's chat more on safety and efficacy. What evidence from Celestial makes CABOMETYX such an appropriate choice specifically for Anna?
I personally like the balance of efficacy and safety that was demonstrated. In terms of efficacy in the ITT population, patients receiving CABOMETYX had a longer median OS than those receiving placebo, 10.2 versus 8 months, and a longer median PFS than those receiving placebo, 5.2 versus 1.9 months. In terms of safety, the most common adverse reactions in the ITT population with an incidence of greater than or equal to 20% were diarrhea, fatigue, PPE, hypertension, vomiting, nausea, and decreased appetite.
And how do you approach managing those ARs?
Really, managing these ARs are the work of you and your team. But as you know, dose modifications, along with extensive patient education, proactive clinician engagement, and the crucial involvement of a multidisciplinary team are key approaches to management. It's essential to closely monitor patients and educate them about potential ARs, as well as how to recognize and effectively manage these symptoms.
So we started talking about the Celestial trial because of the enrolled Child-Pugh A patients who then progressed to Child-Pugh B status by week 8. I assume that data played a role in your decision as well.
Yes, and I definitely find that data compelling for patients like Anna. Among patients receiving CABOMETYX who progressed to Child-Pugh B by week 8 of treatment, they also had a longer median OS, 8.5 versus 3.8 months, and a longer median PFS, 3.7 versus 1.9 months, than those receiving placebo. These results were similar to those of the main study population. I should note these results are from a retrospective exploratory analysis of a relatively small number of patients, and the data are not considered substantial evidence and should be considered hypothesis generating.
And what role did the safety data for the child Pu-B subgroup play in your decision to choose CABOMETYX for Anna?
That's also critical information, especially due to the extent of Anna's underlying liver disease, and it made the ARs seen in the trial especially important to consider.
Was there something specifically you were keeping an eye on?
Well, the most common ARs were decreased appetite, fatigue, diarrhea, nausea, ascites, and hypoalbuminemia. But as I said, I would try to manage those with dose modification and keep her on therapy as long as is appropriate. In the Celestial trial, the efficacy results were seen in the context of dose modification and interruption. The rate of dose reductions in the child Pu-B group was 61%, while the rate of discontinuations was 18%. It is important to note that not all side effects can be managed. Some might require permanent discontinuation of CABOMETYX.
This is where partnering with a hepatologist is especially valuable for me. They help me make sure the diuretics are optimized and make sure the patient's lactulose dose is right, and that their electrolytes are in a good place. So, when initiating CABOMETYX with Anna, would you start at the 60 milligram dose that was initiated in the Celestial trial? What dose of CABOMETYX did you choose, and why?
While 60 milligrams once daily is the starting dose for CABOMETYX, in Anna's case and for all patients with child Pu-B status, you should reduce the starting dose of CABOMETYX to 40 milligrams once daily. And you should avoid CABOMETYX in patients with severe hepatic impairment, like child class Cs. Overall, in the Celestial trial, the mean average daily dose was 37 milligrams in the ITT population, as was the median average daily dose in the child Pu-B subgroup.
I think it's really important to counsel patients up front when you start a therapy that there will be bumps in the road. In some cases, we can adjust and move forward. Lowering a dose is okay. In my practice, I've held and lowered the dose from 60 milligrams to 40 milligrams, and then from 40 milligrams to 20 milligrams. The efficacy that was seen in the Celestial trial took place in the context of appropriate dose reductions. So, in summary for Anna, who progressed to child Pu-B7 status, you chose CABOMETYX as her second-line treatment because, in the intention to treat population, Celestial demonstrated a longer median OS than those receiving placebo, 10.2 versus 8 months, and a longer median PFS, 5.2 versus 1.9 months. Celestial provided data on patients who progressed from child Pu-A to child Pu-B status, which might be worth considering. In this exploratory subgroup analysis, outcomes showed longer median OS, 8.5 versus 3.8 months, and a longer median PFS, 3.7 versus 1.9 months, compared to those on placebo. And you felt that with dose modification, you may be able to manage some of the ARs and help keep Anna on therapy as long as appropriate.
Exactly. Thank you so much for discussing this case with me.
It was my pleasure. And I look forward to discussing our next patient case. Stay tuned for our upcoming CABOMETYX in Conversation session.
Important safety information, warnings and precautions. Hemorrhage. CABOMETYX can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in CABOMETYX patients in RCC, HCC, and DTC studies. Discontinue CABOMETYX for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of CABOMETYX patients. Monitor for signs and symptoms, and discontinue CABOMETYX in patients with grade 4 fistulas or GI perforation. Thromboembolic events. CABOMETYX can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of CABOMETYX patients. Fatal thrombotic events have occurred. Discontinue CABOMETYX in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. CABOMETYX can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of CABOMETYX patients. In CABINET, N equals 195, hypertension occurred in 65%, 26% grade 3 of CABOMETYX patients. Do not initiate CABOMETYX in patients with uncontrolled hypertension. Monitor blood pressure regularly during CABOMETYX treatment. Withhold CABOMETYX for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue CABOMETYX for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. CABOMETYX can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with CABOMETYX as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. CABOMETYX can cause diarrhea, and it occurred in 62%, 10% grade 3 of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold CABOMETYX until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar plantar erythrodysesthesia, PPE. CABOMETYX can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold CABOMETYX until PPE resolves or decreases to grade 1, and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Proteinuria. Proteinuria was observed in 8% of CABOMETYX patients. Monitor urine protein regularly during CABOMETYX treatment. For grade 2 or 3 proteinuria, withhold CABOMETYX until improvement to less than or equal to grade 1 proteinuria. Resume CABOMETYX at a reduced dose. Discontinue CABOMETYX in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. CABOMETYX can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to CABOMETYX initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold CABOMETYX for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold CABOMETYX for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. CABOMETYX can cause impaired wound healing. Withhold CABOMETYX for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of CABOMETYX after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. CABOMETYX can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue CABOMETYX in patients who develop RPLS. Thyroid dysfunction. CABOMETYX can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of CABOMETYX and monitor for signs and symptoms during treatment. Hypocalcemia. CABOMETYX can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of CABOMETYX patients, 2% grade 3, and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume CABOMETYX at a reduced dose upon recovery, or permanently discontinue CABOMETYX depending on severity. Embryo-fetal toxicity. CABOMETYX can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with CABOMETYX and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are CABOMETYX as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the CABOMETYX dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the CABOMETYX dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during CABOMETYX treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the CABOMETYX dosage. Avoid CABOMETYX in patients with severe hepatic impairment. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.